It's my great pleasure to welcome a panel that will be addressing the fact that neurological conditions are much more than just a health problem. So with me today, I have Margaret Irvine, who's from Legal Aid and has been intimately involved with something called the DARDY project, which I guess she will talk to you about, but an incredible project, so look forward to hearing more about that. We have Janet Wagland, who is the General Manager Community of Brightwater Care Group. We have Elsie Blay, who's the Executive Manager of Services at Ruah Community Services. And we have Richard Newman, who is the CEO of Carers WA. So thank you for joining us here this afternoon to talk about some of the things that you see are relevant to this group in terms of how neurological conditions impact on the work you do. So I might start off with the first question, which is just around telling us about your organisation and what involvement that you have with people with neurological conditions. Richard, I might get you to start. I know that many people in the room are carers, so I'm sure they're interested to hear your perspective.
Sure. Thank you. The joy of being on the end. You get to go first. So Carers WA is an organisation which supports family members and friends who care for somebody with an age, who is aged, frail aged, a disability, mental health, a drug and alcohol dependency, or in this case with a neurological condition. There is around 320,000 carers in WA, and that is a phenomenal statistic, 1 in every 8 people. And I noticed when we had with Tissa this morning, spoke about 100 million people around the world with stroke, 100 million people from COVID, 50 million people with Parkinson's and those type of statistics. Every single one of those persons has a family member or friend. For us, we're talking about 1 in 8 people, of which 35,000 of them in WA are young carers. So we're talking about 8 to 24-year-olds who are doing the caring of a family member or friend, and in most cases are doing the adulting because the parent is incapable. Those statistics are pretty frightening, but they're also very real. What does it mean for somebody with a neurological condition? It means when we talk about, and Karen spoke about it and Rachel spoke about it this morning, about the importance of family and friends. When you support a person with a neurological condition, don't forget that there's 4 or 5 people around them who are actually intimately concerned and play an intimate part of their welfare and their well-being.
Thank you. Janet, you work in the space of care as well, so do you want to tell us what your organisation does and how you're involved?
Okay, so Brightwater Care Group has been around since 1901. Those of you who are old like me probably would remember it as Homes of Peace. And what I like to remind the organisation of occasionally when I get the chance to slip it into aged care is that the first person who was ever admitted to the then Homes of Peace was a guy in his 40s with neurosyphilis. So basically we've been providing services for people with neurological disabilities since 1901. Now we're a bit more modern, I hope, in our approach to those services. And my part of the business provides a diverse range of services for people with neurological disability, from supported independent living, which is long-term care, predominantly for people with acquired brain injury, but we do have a number of people with Huntington's disease who we're currently rebuilding our accommodation services for. We have community-based rehabilitation for people with acquired brain injury. We have transitional services for people with complex needs who have been stuck in the hospital system. And we also run a range of NDIS-funded services around therapy, behaviour support practitioners, support coordination, nursing, to ensure that we're there for people who are living in the community as well. But I'd be remiss to neglect the fact that our residential aged care services, whether it's in the community or in our aged care facilities, are also providing services for a large number of people with dementia, so as well as other neurological disabilities. Yep.
Thank you. And Elsie, you provide sort of accommodation. Do you want to talk about your role?
Sure, thank you. Ruah Community Services provides support for people who are escaping domestic violence. We provide services for people who are sleeping rough, in homelessness services, mental health, and also legal supports. Ruah's been around since 1959, and we've long-standing experience in providing support for people who are the most vulnerable in those times of need. I think the link to neurological injury and disease is really relevant. We know that 1 in 3 people who are sleeping rough have a neurological injury or condition. What that means for us is that huge amount of undiagnosis due to the difficulty to access, shame, stigma, mistrust in the system where people have been let down so many times. They come to us with existing neurological injuries or diseases, and being on the streets is a huge contributor to injury and assault. We have people who have come to us directly from being assaulted, either escaping domestic violence, the injury itself, non-fatal strangulation, and abuse and assault on the street. So it's really constant for us in the approach that we have to neurological injuries.
Thank you. And Margaret, you're from Legal Aid, and there's an awful lot happening in the media in that space.
Yes.
Do you want to talk to us about how you're involved?
Hi everybody, thank you very much for having me today. My name's Margaret Irvine. The best way to describe my project, and not because I'm big-headed, is maybe talk about myself for a little bit. But essentially, my background was, you'll be surprised to know, not Australian, I'm Scottish. And I was in Glasgow working in accident emergency for several years. Now, our A&E department was one of the biggest ones in Europe, and our speciality was head injury and trauma. So it's something that's probably very close to me and I've been working with for nearly, I'm ashamed to say, maybe 30 years now. But I came over to Australia and I became a lawyer, retrained as a lawyer. It's the same job done different. What happened, when did it happen, how can we get a good outcome? And my big passion is young people. Because when I came to Australia and realised that we were incarcerating 10-year-olds with complex needs and disabilities, I thought, where the hell are we going wrong here? Essentially, DARDY is disability advocacy, referral and diversion for young people. Young people under 25, anyone who is across this area will know the brain's still developing up to the age of 25. Throw in childhood trauma, throw in PTSD and all the other things that go along with that exceptionally vulnerable area, and we're dealing with exceptionally complex young people. The DARDY has been a passion project for about 5 years, and it's finally up and running for over the last year. We've had amazing support from ETA, from Bruce, and from many organisations across the state, in which we're incredibly grateful, including Ruah have been amazing also. Our aim is to do it differently. Stop looking at law as a punitive approach, look at it from a therapeutic, holistic, collaborative approach, and that starts with events such as this, everyone working together. So what we do is we look at the young person as a whole, and we look at the offence and say, well, what's going round in the background? Why is there a reason for offending? In Banksia Hill, just for some stats, or for juvenile detention, at any one point, usually there's anywhere between 70 and 85% of young people have got a neurocognitive or psychosocial disability, diagnosed or otherwise, in detention. Often there's cultural complications where they are from a culturally diverse background. Linguistically, English may be second and third language. They may be displaced from a remote region and brought down to Banksia, so they're absent from family. And our job and our project, simply put, is to connect them, have young people re-engage, feel connected, feel part of the community and feel that they are valued. Most importantly, let them be heard, because many of the young people who are in that situation are not there of their own making or their own volition. So we look at the holistic picture. We build a model of support around that young person, not only to get them out of custody, but also to work with the family, look at needs in the family. And as you quite rightly said as well, we have to be eyes open to carers that are in the community and recognise carer burden and carer responsibility. So we actually look at that as well and look at the supports. But most importantly, we don't exist for the period of the legal problem. We actually exist until they basically tell us, we don't need you anymore. And the beautiful thing about DARDY is what we want to do is we love social reinvestment, and the message from social reinvestment, WA's blueprint for change, which is give young people their voice back, allow them to be heard and seen, and also give them ownership. So the project aims to give people ownership so young people can transition through a project and become future mentors, future support workers, anything they want to do. And that's the message we give to young people, is it doesn't matter about your past, it matters about going forward. We are here to be with you and we believe in you. So that's DARDY in a little nutshell.
Thank you. I might stick with you then and just
goodness.
ask you, while you're on a roll, what are the challenges for your organisation in managing or supporting the growing number of kids with neurological conditions?
I'd like to talk to that and also talk to the challenges generally within this space. Taking time with people and understanding that neurodiverse isn't necessarily a negative, it's just different. And actually for lawyers and support workers and secretaries and people who work within the corrective services and court system to take that time to understand that young person. And quite often the challenge is they're so busy with the processes, they're so busy with we need to get an outcome for the client that we miss the actual client themselves. And for me, that's one of the biggest challenges we have, and that's why we're working on client-centric work. Another challenge, in order to deliver a proper, robust support mechanism for young people, is collaboration. Collaboration, we recognise that we're not always the best answer for young people, but if we can come together as a community and recognise actually this organisation here can provide this service, this one here can provide that, then that collaborative village, and I always talk about it takes a village to raise a child, that village approach is the best solution. However, a lot of siloing still exists in WA. My opinion is, my personal opinion, not the opinion of Legal Aid, is siloing exists a lot due to funding. Organisations are pitted against each other to get a little bit of the crumbs of the pie, and I think by us actually coming together and working together collaboratively and recognising each other's strengths and learning and growing from each other, we can overcome that barrier. Information is a huge issue and knowledge is a huge issue, but they're all surmountable, again, with people collaborating and working together. With young people that are in detention, again, the secret to success, I believe, is knowledge. You have to understand that young person and understand what their capacities are and what their limitations are and teach each person individually. But unfortunately, we have a overcrowded, overburdened and underfunded system, frankly, where it's the one methodology suits all. And while we keep going along that one system suits nobody, we're never going to get ahead. So that's what we're trying to do, is change that dynamic and look at individualised, tailored solutions.
Thank you.
Thank you. And
Elsie, you're in a very similar situation with a growing number of people. What are some of the challenges for your organisation in supporting people?
So I think, similar challenges in terms of organisations, and we definitely agree that, a collaborative approach is key. I think for neurological injury and conditions, what it looks like for us is understanding what's in front of us in an acute episode and what's gone past. I was at the Safe Night Space the night before last, which is a drop-in, low-barrier service where you can just present whether you're homeless or escaping violence. And I was talking to this lady, and she's an academic, she's an incredibly amazing woman who's ended up in a situation where she's homeless. She'd just been discharged from a neuro ward, her eyes completely red, her skull fractured, just incredibly positive somehow, but, had an incredible situation. And she was talking to me about the, shaken baby, FASD, and all the neurological impacts that stack up well before an acute assault. And so I think, the challenges for us in looking at the person, as you say, is that she's trying each night to keep herself safe, warm, yet alone employment, yet alone kind of recovery journey, and to then have a neurological assault or an injury so serious. As a non-clinical workforce, that's really difficult for us. So we link in amazingly, and so grateful for everyone in the room who provides link-in support, but we're there to provide that psychosocial support. NSQHS accreditation has really helped us in terms of equipping the whole workforce around, falls prevention, what does deteriorating clients look like, and those kind of things. But the truth is that we're not funded and we're not a clinical workforce. So being able to understand when there's a problem, what a deteriorating person looks like, as a nurse with basic kind of skills around what a sick person looks like, that's really simple. But trying to translate that onto a support worker who's there to provide food, accommodation and shelter, and to know that their gait's changed or their speech has changed, or what else could it be? I think that's a real challenge. So yeah, I think that's probably the key one for us.
Great, thank you. And Janet, again, your organisation is quite unique in the space in terms of providing accommodation for people with quite significant injuries. Do you want to talk a little bit about what some of the challenges are for your organisation?
I think, I could talk to you, Etta, about, I want more money, or, I want better responses from government departments and be able to have everybody work a bit more cohesively in those spaces. But I think the challenge that I see as the biggest one is I would like, for many of our clients, our guys with Huntington's disease, who come to us towards the end of their journey, or our clients with brain injury, many of whom I keep saying to the staff, we're only a blip in their lives because they're moving on, and I want them to move on to other spaces and to other services and back into their homes. It's the lack of those other services and resources out there is the biggest challenge. So, when the NDIS rolled into town and it absorbed a lot of the light touch funding, so many of those smaller, sort of more discrete services that provided just a bit of support to help people with things like their housing, being able to ensure that they were managing their finances, ensuring they were managing their relationships. And it's things like that that keep people out of the health system and keep them out of systems like ours, or also enable us to be able to discharge people back and often into the community. But we've lost so many of those services, and then the bigger services that we really have challenges with is that there isn't enough housing. There's not enough community housing in accessible spaces and in communities that are going to wrap around people to enable them to access their shops and their pharmacy and their doctor. The primary health supports are often a challenge because as much as the GPs are really trying, they often don't totally understand neurological disability and how to support people effectively. Then we have the big challenge of that crossover between the tertiary health system and the mental health services, and often our clients are being bounced back and forth between the two of them, with mental health saying no, they don't belong with us, and tertiary health saying no, they don't belong with us. So how do you actually create wraparound services that aren't us, because we shouldn't be in people's lives for the rest of their lives, that enable people to get back out into the community and live the lives they want to be living, or with our people with neurodegenerative disability, how do we keep them out in their community and safe and well for as long as possible before they have to access our services?
So what are some of those missing services, Janet?
I think the missing services are those ones where people can just pop in and make sure that somebody's safe and okay and looking after themselves and keeping well, and help guide them into the support services they need. Certainly better cohesion between mental health services and primary and tertiary health services, all of that connection between those services would make our job a lot easier, even if somebody is living with us long term. It's a hard enough job to be able to ensure people live good lives without having to fight with systems that really should be there for you and responding.
Yeah. And how many places do you have? You have a couple of facilities, do you?
So we've got 2 places for people with Huntington's disease at the moment. One is 6 bed and one is 12 beds. We're going to be expanding that capacity when we rebuild. We've got 48 places for people in our brain injury rehabilitation service. And help me here, we've got about 60 places for people with brain injury in supported independent living, which is our permanent care services, and that kind of goes up and down a bit depending on how we manipulate our beds and use them. So we do have a number of residential places, 23 for transitional services, but really, we could actually provide far more effective and broad-ranging services to a wider range of people if we actually had better connections to move people on and out from us when they can go, or to prevent them coming in the first place. So how do we actually get a better balance of service provision for people on their journeys?
Yeah, because it's a relatively small number compared to the number of people that really need those services.
That's right, yeah.
And Richard, you come from quite a different perspective in terms of looking at, and not the patient, but the carers. So what are some of the unique challenges from your organisation's perspective?
I think Janet's absolutely right. It's about that village approach. It takes everybody to, address these concerns. A carer will typically not engage unless they're in time of crisis. And there's 4 social determinants that usually determine that. One is lack of recognition, the other's lack of support, and the other is problems with support, and also trouble with engaging with other organisations. When you have that perfect storm, a carer will usually engage in some way, shape or form, but at that point it's crisis. And WA has the highest number of carers in crisis than any other state in the country. And we're up around 25 to 26% of carers who are basically just saying, I can't cope with my caring situation, regardless if it's neurological, aged care, drug and alcohol, mental health or whatever. So for us, it's a bit of a two-stage approach. One is, what is the immediate concerns that need to be supported for the carer? And this is around what services is going to take away that stress, that immediate crisis point. How do we engage? How do we carry those conversations? Who do we pull in from other support organisations and other parts of the community? And how do we get that in place where the carer is not feeling like they're being isolated, being left alone, and all the focus is on the care recipient or the person with a neurological condition? Then you start to build a long-term sustainable relationship and partnership with the carer that says, what are you going to need in the future? What are you going to need now? But then what are you going to need in 6 months, 12 months' time? What does that carer journey look like? And unfortunately, with a lot of neurological conditions, the carer journey starts with moment of impact. It's very rarely does it grow. It starts and it's sudden and it's horrific, and people are just emotionally devoid. They're going straight into stress control, straight into, I need to look after this person straight away, regardless of what my own well-being and my own health looks like. And then the carer journey gets harder, because a lot of neurological conditions, a lot of illnesses are degenerative, and so that moment of impact is when it all starts, but it carries on, and it has an end, and that usually, unfortunately, is when the person is moved into permanent care, into a medical condition, or unfortunately, they die. But the carer journey doesn't just stop there. How do you support the carer? Once they get past that whole journey, they're suddenly left alone. They've got no income, perhaps given up their family home, perhaps given up their job, all those types of things. How do you then start to support that carer and then link them into the services and supports that are needed? Yeah. So it's a moment of impact kind of issue, and then it's sustainability and long-term well-being of the carer.
Yeah. So Richard, I was talking to you earlier about my mum having had motor neuron disease and being a carer for a period of time, but I certainly know lots of people around my age have caring responsibilities of children and elder care that they hadn't experienced, their parents hadn't experienced the elder care. So are you finding that carers are far more taxed in terms of the needs being asked of them?
Look, absolutely, and obviously most of the people in this room have heard the terminology of sandwich generation, when you're caring for your children and then you're caring for your ageing parents. And so carers are often in that situation where they're caring from both sides of the spectrum. Nothing is there to support the carer themselves. They're not focused on their own well-being. They're not focused on how well they're doing. They're not focused on, what am I going to do next week? They're focused on the here and now. How do I feed my family? How do I keep a roof over their head? How do I send my 8-year-old son down to the post office to pay the power bill because I can't stop from caring for my elderly parent? It's right across the spectrum, I think, 101. I can't pinpoint one particular.
Thank you. Okay, and so then let's talk a little bit about some of the opportunities for collaboration. Where do you see opportunities for us to work together to improve the lives of people with neurological conditions, or even our social or economic indicators? Do you want to start?
Collaboration is everywhere. and it's anywhere you want to make it happen. You just have to have the will and the determination. I think it's the key to success. I go back to it takes a village to raise a child, and you know, although I deal with young people, I actually deal with people across all ages at Legal Aid. Before I came into criminal law again, I actually worked in NDIS appeals solidly for about 3 years, and that was the start of the kind of collaborative exploration across the community, because we can be quite insular as professionals and think we're the solution for that person. We're not. And I think, you know, having that lovely collaborative approach with the NDIS appeals, we'd speak to speech pathologists, neurologists, OTs, anyone, support workers. We've seen that beautiful bubble worked really, really well for that young person. So collaboration is everywhere, and I think it's not being afraid to reach out your hand and ask for help. It's okay to say, I don't know what I'm doing here. I don't understand what this is. Is there someone there that can help me? But it's hard, especially, you know, when we go back to carer responsibility and sandwich generation. I completely agree with yourself. I have aging parents that we care for, and children as well. We put such a burden on ourselves to be perfect and to do the perfect job and the best we can. And sometimes when you can take a step back and actually look from the outside and see it from either someone else's eyes or ask someone else for help, that's when the change can probably happen, and for carers as well, so that you don't get to that burnout phase and the burnout stage. Our project, I think we were kind of one of the early ones, and there's different projects that exist within Legal Aid, but we were one of the ones that really, really went out and said, we actively want to work in the community. We want to work with First Nations services, we want to work with clinical providers, we want to work with diverse communities, we want to work with agencies, also with different government agencies as well, and that's a little bit unique, because again, the government exists in silos for some agencies as well. You know, communities might not always speak to justice, who might not speak to corrective services or speak to us, and part of that has been bringing all those agencies together as well. And some of the work that's starting to come out of that collaboration, which includes the Children's Court seeing the opportunity to create a therapeutic court, which is the coming together of minds. I mean, some of the things that are coming out of that court already are just incredible, and it's definitely the way forward, but it's not an easy process. And for anyone who's looking to do anything, you know, in that kind of sphere, or you taking a collaborative approach, don't be disheartened, you know, and if the door gets slammed in your face, knock it a couple of days later and try again. People in this room, Bruce, I can see you nodding, will know that I'm pretty persuasive, but I'll just keep coming back. If I think it's right for a client, we won't take no for an answer until a client tells us it's a no. But stick with it, and you know, when we work together as a community, it definitely shares the load, half the load.
Thank you. Pleasure. And Elsie, I think Ruah is one of the great collaborators of Western Australia and such a success story. Where do you see opportunities for collaboration or impact investment?
Yeah, I think definitely agreeing with the team. I think it's hard, and I was talking to someone before around that competitive tendering and how do you break that. But I think, you know, the strong relationships and everyone having a focus on what we need to do and what the outcome is, everyone's actually pretty amazing. And when you kind of forget that it's okay that we'll tender for the same thing, we're all going for the same thing, and if you win it was better than mine, so that's amazing, because it's going to be incredible for the sector. So I think in terms of partnering in relation to kind of neurological injuries that we've seen, around doing more of what works. For us, it's having a psychosocial support next to a medical support. You know, talked before about the scope risks and things of not having medical support. Our after-hours support team, we have a social worker and a nurse going out together, and that's really key with Homeless Healthcare as our partnering agency. MCOT, kind of groups like that who come in and do in-reach into our services is really important. We've just got the Enhanced Service Delivery project running, which is really exciting because it's got the flexibility that's not funded by others. And so, you know, being able to do that's been a game changer for us. We've got a disability navigator, 2 counsellors, child advocate, financial counsellor, and the demand for those services who are like extras or ninjas in the team is just huge. To be able to not have a contract to follow, not have a criteria, just do what's needed, support someone as long as they need it. If the kid needs school shoes and that's the barrier, get them the shoes. So that's been really pivotal for us, and also our new Access and Inclusion project, which is around identifying disability early, training, linking in with groups like Synapse who are really supportive to us, all those kind of things to be able to build capability. So definitely I'm so pro collaboration. Call me, message me. I love it. Yeah, as well. And I think the more of doing what works and understanding that we're all on the same team, it's okay if we tender for the same things. Yeah.
Fantastic, and you are doing an amazing job. Thank you. So Janet, again, you're in a unique space amongst us. So tell us a little bit about where you see collaboration, and you have been in this sector for a very long time, so you've seen so much change through it. I'm really interested, and some of these things may have been tried and tested 20 years ago too.
I sometimes feel like we go around in circles and come back to the beginning again. I guess we're in the unique situation, particularly with the rehab service and the transition service, that we're actually referring into other services. I really loved Karen's analogy about joining hands, and I just wish that we would all join hands a bit more effectively to be able to do it in a way that's visual and obvious, because to me, if I as a service provider am having challenges in being able to understand what's out there in the sector and refer people on and map services for them, how are individuals themselves going to be able to find those services and access what they need and be able to cohesively pull together a journey for themselves to follow to be able to achieve the outcomes they want to? And I think, so often we've been almost like little disparate service providers all over the place that aren't really working together. I'm buoyed by the fact that finally we seem to have some cohesion happening, that Synapse has finally mapped all of those brain injury services that have been driving me spare for years, so that people can actually look them up and find them somewhere. But really, how do we pull all that information together so that people can actually see it for themselves and have control of their own journey? We talk a lot about person-centred care, but I'm much more of an advocate for client-driven or patient-driven care. Ultimately, if we don't teach people to be able to control their own journey, we're not doing our job. So how do we actually provide them with the resources and the line of sight to be able to do that? And I think that's where we should be investing so much more of time and money.
Yeah. And there's some really good work being done in the digital space in terms of platforms. Certainly Travis over at ECU and he works with Perrin as well.
Yep.
And Gareth, they're putting together some platforms where a lot of this information could potentially be housed in a central location that would make it easier for people who already have challenges to be able to access the information. So good point. Now, a few of you have touched on the NDIS, so please, you've got 1 minute. Give us a bit of an indication of how NDIS has changed things either for the better or for worse. And maybe Janet, you want to comment there?
Geez, a minute's nowhere near enough. Basically, for us and our services, the challenges of having the NDIS running interference between our services and the health system is really a problem. We're ending up with people with funded packages moving straight out of hospital who normally would have come to us for rehab who aren't having that opportunity, so they're not rehabbing. And we're getting people into rehab who have got, double the number of comorbidities that they used to have and more subacute. So we're actually getting the people who are less likely to achieve really good outcomes in rehab and missing the ones who really could have had some. And then to sort of double the problem, we're then often fighting with planners and support coordinators who are not necessarily clinically trained in anything, who are then arguing with us about what the person actually needs when they move on and out of our services. And so really the NDIS is not working in a connected, cohesive way with any other systems, and health is just one example of that, and to me that's a huge problem.
Yeah, one of my favourite comments that was made by one of our neuro nurses was where a coordinator had asked a neurologist whether or not the person had considered brain surgery as another resort before they handed them the NDIS. And I think how a support coordinator could be questioning the report of a neurologist is extraordinary. All right, look, we have run out of time, but I thank you very much for the short, sharp assessment of the situation as far as your respective organisations are concerned. And we absolutely look forward to collaborating as a group. So can you thank our panel, please, Elsie, Margaret, Richard and Janet. Thank you.